Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Lewis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232, and that number is in the chat. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon at the in the meeting control toolbar. Actually, now it says subtitle, show subtitles. So Zoom changed it on us. To toggle that meeting control toolbar permanently on, you can press the Alt key once and then press the key a second time. As always in our sessions, only the speakers will have audio. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656 and use the webinar ID of 837-2204-3591. Those numbers are also in the chat. All right. I want to remind you that the webinar is being recorded and will be able to be seen on the adapresentations.org website in the archive section of the healthcare area next week. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the Americans with Disabilities Act of 1990, the ADA. Upcoming sessions are available at adapresentations.org under the Schedule tab, then go to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open the webinar to registration. You can follow along with the slides on the screen. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the healthcare schedule page at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session, so feel free to submit them as they come to your mind during the presentation. You may submit your questions in the chat box. You can press Alt H if you're using keystrokes and enter your text in the chat area. If you are listening by phone and not logged into the webinar, you can ask your questions by emailing them to adatech@adapacific.org. And that is adatech@adapacific.org. If you experience any technical difficulties during the webinar, you can send a private chat message to the host by typing in the chat window. Type your comment in the text box and enter. Again, if you're using keyboard, use Alt H to get that chat box and then enter your message. You can also email us at adatech@adapacific.org or call us at 1-510-285-5600. Today's ADA National Network Learning Session was titled Effective Communication, Leveraging Alternate Formats in Healthcare. The Americans with Disabilities Act requires that covered entities communicate effectively with people who have communication disabilities. It is essential to ensure that communication is equally effective for all. Ensuring that we engage in effective communication in every aspect of life is key to successful relationships in both personal and professional. This webinar will review how to effectively leverage alternate formats in a healthcare setting to ensure that the principles of effective communication are being met. So today's speakers are Gabriel Uribe. Gabriel is the Director of Community Health at the Inland Empire Health Plan. His contributions in the area of community health program design, diversity and inclusion, policy development, and social innovation have been key to the development of community collaboration initiatives in the Inland Empire Health Plan's catchment area. Carla Argondona is a senior policy analyst at Inland Empire Health Plan in their community health team. She is responsible for the implementation and development of enterprise-wide social support programs. She is a leading expert in healthcare communication accessibility for people with access and functional needs and has been with IEHP since 2015. So Gabriel and Carla, I'm going to turn it over to you now.
Well, thank you for that wonderful introduction and for inviting us to have this conversation with a group of individuals who are highly interested in communication services for people with disabilities and access and functional needs. It is a pleasure to be here today. Carla and I have been excited and talking about today for a while, and we hope that the information that we share today is of value for you and your organization. But more importantly, for the folks that you serve through the communication pieces that you deliver on a daily basis, because communication is at the cornerstone of all we do as individuals in business and in practice. So we'll go ahead and go to the next slide and give you a quick overview of what we will be chatting about today. I will give you a quick, just 1 minute, who IEHP is and what we do. We'll then go into an effective communication overview. I have a feeling most folks on this in this presentation here today or this webinar already have an idea of what that is, but there might be a few points here and there that we will highlight and consider for the purposes of the conversation. We will then transition into what alternate formats are and how those are processed and delivered for members, followed by some conversation around health policy that has been in effect for a long time through the ADA, but more recently highlighted by regulators around Medi-Cal Health Plans in California and some Medicaid and CMS plans that are regulated by CMS, including Medicare plans around the country. And we will close with how we've worked to build communication capacity in the alternate format space and communication space here at IEHP, and share some best practices and stories of what we've seen over the years. So we'll go to the next slide. A little bit about IEHP. IEHP is one of the top 10 largest Medicaid health plans and the largest not-for-profit Medicare-Medicaid dual plan in the country. IEHP serves low-income individuals and families in San Bernardino and Riverside County who are living under the 138% poverty line in these two counties. We currently have about 1.4 to 1.5 million members, meaning that we serve 1 in 4 members in the two counties, which in a way it sounds impressive because it's a big number for two counties serving 25%. However, it is a figure that often brings some sadness to us because we understand that 25% of folks living in our two counties are living under the poverty line, which is a significant social impact for the work that needs to be done here. We do have a network of about 7,000 providers, and this includes primary care physicians, specialists, therapists, ancillary services, and we have about 2,500 team members that currently support the operations of our network to ensure that all 1.4 to 1.5 million members with an IEHP are serviced. I will say that about 150,000 to 200,000 members with an IEHP are seniors and persons with disabilities. And the reason I call out that number is because we understand that seniors and persons with disabilities have access needs that are about 8 times that of a person without a disability, meaning that just in that cohort, we see a higher need and utilization for individuals with access and functional needs and disabilities. Next slide. So what is effective communication? You know, when we think about communication, I think we always go back to, especially when you're having conversations about how confusion in the workplace, perhaps in your personal relationships, communication is always at the cornerstone of some of the misunderstandings that happen in day-to-day life. Communication at a traffic stop is nonverbal or could be nonverbal, but it's definitely visual. A person stopped at a traffic light knows or should know, if they have a license, that green means go, yellow means prepare to stop, and you know, in California it probably means go faster before the red light comes on, but red definitely means stop. And when we don't have clear patterns of communication, things that are overtly obvious and understood by many folks, you often tend to have communication gaps. So this is not something that is new to us, but we'll start talking about it through this framework as we cover our conversation today. So if we go to the next slide, we in the disability community know that there are effective communication alternatives to that of the mainstream. And by the mainstream, I mean mainly folks without disabilities, individuals who have their hearing, their vision, may not need some of these services. However, as vision or audio or hearing is lost due to disability, to aging, we may require some assistance or additional supports to ensure that our interaction with our environment is more successful, and especially around the communication space. So the first sign here we have, communication may look like sign language. It might be something, it might be visual. We might need support in a visual space to communicate with folks because of their abilities. We may need assistive devices. Assistive devices can be amplification devices. It could be devices that provide captioning services, like in this Zoom call today. You are seeing the ability for us to caption this conversation by clicking on the button. So that is an assistive technology. We also see things like Braille that are physical, tangible, either paper or machines that raise these little bubbles that allow us to read information through that communication method. We also may have some assisted devices for hearing that allows us to amplify the information that's coming into our ears. The most common one that we've seen, and you'll see in the data that Carla will go over towards the end of our conversation today, is that large print is often the most requested alternate format for most organizations, because as we age, many of us as we age, whether we have a visual disability or not, our vision starts to not be as strong as it was when we started off. Maybe some of us started off with 20/20. We were blessed with that vision. That's great. If you were not and you have a 20/30, you might use glasses now. But as we age, most of us will tend to lose some of that refined vision, and we start getting into spaces where we need a little bit of help through large print. And finally, TTY, which is a way to communicate either through the telephone using text and using teletype texting types of machines and other technologies that are available through our telephones, and emerging technologies, things like text as well, that are available in chat rooms and websites and so on. So this is just to give us a kind of an idea of what these different modes of communication are. If we go to the next slide, we know that assistive devices have significantly evolved over the years. Here you see two older devices here, or devices that were invented a few years ago, but this still provides significant assistance to folks that can amplify things like textbooks, put that information on a screen. We do have large libraries now of audio technology for folks to use. However, some of these devices continue to be used, even though they may be considered lower tech or more cumbersome tech because of the size of the device, but may be still needed if folks do better by actually seeing the text in a space as opposed to listening to the information. So considering also learning modes, learning disabilities, devices and assistive technology may look different for individuals and may not always look or be the mode of device that we may think of because it's readily accessible or perhaps a cheaper technology. So this is a quick example of something that's a little bit bigger. These machines don't do much other than amplify, and they do have a significant cost, but there are other ways to utilize things like iPhones or smartphones to be able to do some of this, but sometimes it may not be the best thing for the individual, depending on their needs. If we go to the next slide, we also have, many folks have an idea of what video remote interpreting is, and many folks have interacted with video remote interpreting, perhaps at an emergency room as a health plan. We do service a network of hospitals and urgent cares that need to provide immediate communication to folks in urgent situations. And although many hospitals in key areas may have, one or two interpreters in different languages, perhaps an ASL interpreter who is on call, who can be present for a consult within 30 minutes. Perhaps sometimes there are needs or geographic areas where this is not, the norm, or it's not achievable. So video remote interpreting through the advances in bandwidth over the internet, through the advances of cheaper, large screen cost technology, can be a viable option during emergent situations to address the needs of individuals who need assistance in a clinical setting and emergent setting. Although I will caveat this, that most of the conversations we've had with stakeholders, at least in the Inland Empire, who are deaf or hard of hearing, have shared that VRI is not the preferred method of communication for folks who use sign. However, they do agree that it is an important auxiliary type of technology for communication when an interpreter is not readily available. All right, so we'll go to the next slide. And when we talk about specifically about alternate formats, I wanted to cover some of the communication basics just for folks that may or may not have some of that information already. But in today's topic, really going into alternate formats in the context of the policy for both ADA and healthcare policy in current state, alternate formats are considered to be services or formats that provide communication access for written communication in a different way. Particularly here at IEHP, we do have contracts that focus on providing individuals with access to letters that they may receive that are very crucial to their information. We call it member informing materials that inform them about their benefits or their plan of care, to be provided in Braille if a person requires it in Braille, in large print, in e-text, meaning electronic text, and there's several versions of electronic text that can be provided in audio, and an emerging space that is not very popular, but we understand that if an organization is able and has scalability to do this, to provide the option for text to ASL. And I'll kind of stop a little bit here in the text to ASL. If you're not very familiar with American Sign Language, you might not know that English and ASL are not the same language. So English is different from ASL, although many folks who use ASL do read or can read English. Many times that is not the preferred method of communication, and B, it's not their first language. So there might be some things that get lost in translation from English to ASL. So we do provide the option for members who are deaf or hard of hearing who leverage ASL to request text to ASL services, meaning that, excuse me, if a member requests a letter in ASL, the letter would then be read by a ASL interpreter and recorded, and that video file would be then sent to the member. So this is just kind of a general overview of what alternate formats can be. I will also say that large print formats, for example, can include larger images, so not just the text, but larger images within a file. And you might have different versions of what a large print material may look like, including the production time for some of these large print materials due to the complexity of what the content that may be in the original text may be. So it's not just a matter of simply blowing up, you know, a letter or a document. There might be some other implications. Same thing applies to e-text and audio. There might be images in a document that a person may be exposed to during a letter in terms with the goal to provide education or provide instruction or provide some level of context to what is in text. Alternate formats also include, or should include when appropriate and when critical to the messaging being provided, audio description or text description of the information that is embedded in the text, especially if a person has a vision disability or a disability that does not allow them to process the image by simply looking at it. So those are some of the other pieces that you know, you have to take into consideration as you look and help folks in the journey of picking an alternate format that is more suitable for them. And we'll get into this a little bit later, but I will also make the caveat that there may be certain documents for which a person may prefer Braille for, but for others may prefer e-text. And often that is due to the level of complexity of the document, or it could also be the level or the length of the document, you know, the ability for the individual to store the information. For example, a multi-page document, let's say a 250-page document transcribed into Braille may take a few banker boxes in terms of what the size of that document might be. And it also may be difficult for the individual to page through some of those documents effectively. So perhaps e-text may be a better option for a 250-page document. And with current technology, we could also leverage accessibility features such as find text or find a section for us to be able to move forward in those spaces. And I think if you don't have an access and functional needs when it comes to communication, perhaps you've used some of these types of shortcuts to be able to access some of that information. So we'll go to the next slide. In addition to you know, communication in a specific alternate format, we also have to look at the needs of individuals who have limited English proficiency. So some members with access and functional needs will also have limited English proficiency, and we understand that it is very important for multicultural spaces to be able to offer communication in the language that the individual feels more comfortable with or understands. And we know that in spaces like California, between 1990 and 2000, we had about an 80% increase in folks who disclosed that they had limited English proficiency. And then we also know that about 19, and I think as latest as 2014, some numbers that we have from lep.gov say that about 19.8 to about 17.5% of Californians currently have limited English proficiency. Now, this is a very, very important, because when folks, if we go to the next slide, have limited English proficiency, we could understand that individuals, at least in the healthcare space, tend to receive a lower quality healthcare because of that communication barrier. Often we see that individuals with limited English proficiency have poorer compliance with medical recommendations. And many times in the medical space, we work with our providers to really create a understanding that when folks are have limited English proficiency, they might just kind of nod their head. They might kind of look at you, but not be very responsive to questions that you're asking because they don't understand them. And we always stress the importance of having an in-person interpreter during interactions with individuals who don't speak the same language, especially in clinical spaces, to avoid some of these perils, including in COVID. We saw this very strongly, that we often have, and I'm just seeing here that I will turn on my camera to facilitate lip reading. So I will do that now. Give me 1 second. Perfect. Okay, so yes, so the disproportionate high rates of infectious diseases can also often be seen in these communities. Now, this is not just because of the interactions at the micro level. Perhaps you see some of the public health awareness messaging that is out there about individual infectious diseases. If they are not produced in multiple languages, you might see that there are some issues in terms of higher rates and mortality rates, even in communications, in populations that have limited English proficiency. Let's go to the next slide. Here are some examples of how you can identify someone with limited English proficiency over the phone. Perhaps individuals are quiet and do not respond to questions. They simply say yes or no, or give inappropriate or inconsistent answers. Members may have trouble communicating in English, or may have a very difficult time understanding what they're trying to communicate. When a member does identify themselves as having limited English proficiency and needing alternate formats, it is important to understand the population that you're serving. Perhaps there are some regulations, and Carla will go through some of that policy shortly, of what that may look like for individuals who are in the healthcare space, and the importance of providing those alternate formats in those languages as well as part of your communication plan. So let's go to the next slide. And this is just kind of what our requirement is here currently in Riverside and San Bernardino counties for Medicaid or Medi-Cal. At this time, DHCS has designated English, Spanish, Mandarin, and Vietnamese as the threshold languages in San Bernardino and Riverside counties, meaning that if you're a member of IEHP, IEHP will provide materials and member-informing materials to our membership in these 4 languages in alternate formats as well. Now, I will say that with some of the languages here as well, an individual, for example, who may use Braille, we may not have capabilities of translating into Braille into Mandarin due to some of the character limitations and the development of Braille in that language. But we will always work with an individual, and Carla will touch a little bit about this, that the importance of having staff that is able to work alongside an individual to provide a culturally appropriate response to the the communication needs of an individual, perhaps through a different method. So with that, we'll go to the next slide, and I'll pass it over to Carla.
Hello, everyone. Good afternoon. My name is Carla Argandoña, and I'll be going over health policy governing alternative formats for Medi-Cal Health Plans and their provider network.
Hey, Carla, this is Louis. Can I break in 1 second before you
Yes.
start? I just want to let everyone know there was a problem with the chat at the start of the presentation, but that has been fixed. So now if you do have your questions, you can go ahead and put them into the chat. Sorry, Carla, go ahead.
Oh, no worries.
And one more thing, Carla, because I know this was an earlier request for
Yep.
me as well on the chat. If you could turn on your camera just so that folks can see your lips.
Yes.
Thank you.
Thank you. And if we can start off with the next slide, please. Thank you. So as of March 14th of this year, DHCS did release an updated APL, which is 22-002, and it's alternative format selection for members with visual impairments. So do want to just kind of go over a little bit of the background information. I'm sure a lot of us are very familiar, but it's the Americans with Disabilities Act. ADA requires that services, programs, and activities provided by public entities must be accessible to individuals with disabilities, including visual impairment. So Medi-Cal managed care health plans are subject to the standards of Title II of the ADA, including standards for communicating effectively with individuals with disabilities to ensure they benefit equally from government programs. And so we know that this has been in effect, but the APL currently that was released did give a little bit of more updated information. So if we can go into the next slide, please. So one of the updates that we noticed is that within the policy, it says that Medicaid plans must accommodate the communication needs of all qualified members with disabilities, including appointed representatives. So that is a new one, and be prepared to facilitate alternative format requests for Braille, audio format, large print, no less than 20-point Arial font, and accessible electronic formats such as data CD, as well as requests for other auxiliary aids and services that may be appropriate. And so one of the also updates that the policy also kind of highlighted is that within our medical management system, we need to be able to record if the request was made by either the member themselves or their appointed representative. So that was something new that the APL actually highlighted. So good question, Laura. The APL is an all-plan letter that DHCS sends out to the health plans when new policies have to be in effect for the health plans. If we can go into the next slide, please. So within the policy is a new one that also came out, and I know that one of the formats that actually had been selected would be electronic formats. And so the new big thing also that came out is that if a member selects an electronic format, such as an audio or data CD, the information may be provided unencrypted, so meaning that it's not password protected, but only with the member's informed consent. So as a health plan, we must inform a member who contacts the health plan regarding electronic format that unless the member is requesting a password protected format, the member will receive notices information in electronic format that is not password protected. So it may make the information more vulnerable to loss or misuse. So health plans must make it clear that members may request an encrypted password protected format or unencrypted. So if the member requests notices and information in a password protected format, the health plan must provide a password. So we must provide a password to the member so they would be able to access the electronic data. So that is a really big ask now with, of course, with cybersecurity and identity theft currently right now going up. We want to just ensure that if our members are opting to receive information encrypted, password protected, that we are able to provide that information to our member. And this kind of brings me back to, having that open communication with our vendors to ensure that our actual vendors who are providing the transcription services are able to provide that password protective option for our members. So we can go into the next slide, please. And sorry. Oh, go ahead, Gable.
Yeah, so how do we build capacity around this? And what I'll do is I'll address one question that came up from Jack. You were sharing, so you live in a small metro version of Phoenix in Arizona, and the hospitals there would probably not really have an idea of how to provide effective communication. So thank you for your question, and the question being, what would be an effective approach to educate hospital staff? Let me turn on my camera here. This notice goes off. So, by policy and by statute, hospitals and healthcare providers in that space are required to have an ADA coordinator and or actually, I should say, a civil rights coordinator. And this is due to the Americans, so the ADA, the Americans with Disabilities Act, but also the Affordable Care Act provided provisions that hospitals receiving federal funding, which primarily is most hospitals, I would dare to say 99.9% of hospitals in the United States receive federal funding, are required to provide a contact known as a civil rights coordinator, or a system that alerts the civil rights coordinator to address some of these concerns. So I would heavily encourage, if you do want to have that conversation with a hospital, you can do that in real time, and that person is designated to hopefully provide immediate assistance or relief depending on the severity of the situation. If it's life-threatening, of course, that is going to be something that needs to be addressed sooner. If it's something that in the tier of acuity is on the lower end, it will take probably perhaps a day or two, or perhaps whatever is deemed reasonable at that time for that response. I believe the other question in terms of the in-person communication, very good comment. It's really important for in-person communication. That's where the assistive devices come through, and providing that ability for us to have effective communication. Here at IEHP, a couple of things that we've implemented. We do have VRI available, although we're not an acute facility at our headquarters. We do have members of the public who will come and interact with our staff. And although we don't have a ASL interpreter on call 24/7 here at IEHP, we do have the ability to provide video remote interpreting or pre-scheduling using a live interpreter with a 48-hour or 72-hour in advance notice. So even the notice policy is incredibly important. We also do have in-person governing board meetings at IEHP because we are a public entity. So we do provide a number for folks to connect and request their accommodations in advance so that we can provide those things. But VRI and also amplification devices are available 24/7 at our facilities. Well, I should say during business hours. We don't really do much business after hours, but they are there, and our staff is also trained on how to use them, access them, and troubleshoot them in case of something going wrong with those. So we do have that process. It's also ingrained in policy and training procedures. So when you talk about alternate formats, we're just touching the tip of the iceberg. There's so much work around this space that needs to happen in order for those services to be readily available for folks on demand and not necessarily with many barriers. So removing any of the barriers that would be reasonable is always the objective. All right, so we'll go into how do we build capacity, and then I'll answer a few of the other questions here or comments. So when you build capacity, it's important. This is in our example as a health plan. We need to build capacity around our network of providers, and that is perhaps the hardest thing to do for an organization like IEHP, where we contract with independent physicians or independent physician associations. We can't really police 100% of our network. We can run quality checks, do credentialing. We can do all sorts of things to make sure that we have a very robust network that is meeting guidelines. But as it comes to be with human nature, and as we see in organizations that tend to have a brand or what do you call it? Even organizations that have what do you call them? Like McDonald's, a chain or that kind of stuff. From store to store, you still might see nuances, although there is a big type of or push to make sure that things are systemic. Sometimes you will have deviation from that system. So as a payer, IEHP is responsible for creating a systemic approach to these services, ensuring that folks are trained, that they have the information similar to what we're providing here today, that they have the technology, that we make sure that there's quality assurance benchmarking that is provided with our networks. But with a network of 7,000 providers with multiple sites across 2 geographic regions that are larger than some states, you could see how that can become very cumbersome, but also even more important because we know that people who are also in rural areas or perhaps very disconnected from centers where there population centers where there might be higher clusters of folks with access and functional needs, when individuals reach out to some of these areas, they may not remember the training halfway through the year that they received a year ago. So constant training access, constant remediation, having a space or a number for folks to be able to call in and request for retraining or services is key. So building those relationships with our vendors, ensuring that we have service level agreements that we can review and say, hey, you were supposed to provide at least 99% response to all of your ASL requests, and it's showing here that you're down to 95% or even 97 or even 98. If you're under the whatever the requirement is, perhaps you build in penalties into your contracting to ensure that you have maximum compliance of your provider network. We tend to say in the disability space, you want to win hearts and minds. You want to have a large stick in terms of policy, but you rarely want to use that because you want it to just be a built-in culture. However, when one of those things does not work, you use or leverage the other to try to make sure that you provide the civil rights access for individuals that they are entitled to by the ADA and other policies to make sure that the compliance is available. And also, I think the other piece is in building capacity is community-based organization collaboration. I shared that in our 2 counties, the preference for VRI is not there. Folks don't want to, when we talk to community-based organizations that serve deaf or hard of hearing centers, we have a big community in Riverside because we do have a California School for the Deaf there. We've heard time and time again that VRI is not the most appropriate way for folks. And I think that's something that you hear across the country, but very specifically, we look at it even at the local level. What do you guys think about VRI? How would you like to see this technology used? What do you expect in terms of in-person interpreting? What would be the best and ideal? What do you think, considering limitations, what do you think is reasonable? What would be reasonable? What is your experience like? So having those relationships with community-based organizations can also inform the capacity development when resources can be limited. So as a health plan, we have, I would say, probably more resources based because of our size than perhaps a smaller organization. But for smaller organizations, understanding and meeting the key word in the ADA, reasonableness, is even more important because your resources are a lot more limited. So how do you really figure out what's happening on the ground? What are people's needs on the ground? What is the community telling you is the most important piece to them? And then taking that into the micro level of what are your specific clients telling you in real time? This is something that I need as an individual with a disability, and kind of taking that all into consideration and developing the best communication plan. Next slide, please. So it's important to, in having these, building a network, in developing relationships with CBOs, sometimes you want to also look at your current process and invite them sometimes to give you information and feedback on your current process. Identifying key players in the organization and building relationships. I said we are an organization of about 2,500 employees. I don't know every single employee that works for IEHP, but I want to make sure that I have a relationship with leadership and information technology and help them understand the importance of communication and how communication, can change the outcomes of care for individuals. And many times, because of technology, also from a cost perspective, we can perhaps even reduce costs simply by adding more technology to some of these instances and providing better care, a win-win situation for everybody involved, and especially around automation. If some of these things can be automated, could we build capacity? Large print being one of them. Large print, if for text-only type of documents, there is simple ways to do that using technology. Now, again, if you have more complex documents, that's a different story. But can you find efficiencies? And Carla will go over the percentage of our population that utilizes large print alternate formats, and you'll see why it's important to find efficiencies, automation in that space as well. Healthcare informatics, just kind of understanding what the background and demographics of the population you're serving is. And perhaps, one of the things that I've shared with folks is we had an entire urgent care network at IEHP, over 57 urgent cares, I think, at the time when this concern came up. And we, healthcare informatics and also our grievance and appeals team let us know that there was a member who was grieving because they were going to urgent care and there was no communication access for them in sign language. And our policy for non-urgent visits is that you have to request an interpreter 72 hours in advance, but if you do it later than that, we perhaps can do it based on availability. And we do our best. Our team always does the best. If we can fulfill a same day interpreter, we will do everything we can to make that happen. But sometimes it's just not humanly possible based on the resources available. So with that said, that was the policy for our non-emergency room care. And then the policy for our urgent or for emergent care was they had to have VRI or access to in-person interpreters. So there is this gap. Urgent cares actually kind of were in this weird space with policy hadn't caught up with this new emergent field of care, which is not your primary care, but it's also not emergent care, it's urgent care. So we didn't have policies and couldn't build a process, around that until, we could have if we would have been more proactive, but the reality is sometimes you're not going to be in every space. People with that vision is not going to be in every space. But when we got the grievance, we were, okay, what do we need to do in this space? And we said, okay, we met with Cody, which is our deaf and hard of hearing CBO in the Inland Empire, who's designated to serve this population through some of the state funding that's available and federal funding. And we said, hey, we want to do more in this space. What do you think we can do? And that's when we started talking about video remote interpreting. And what we opted was we provide video remote interpreting for all of our urgent cares at the health plan cost, including the devices, and train the providers on how to use the devices, utilizing a CBO that had relationships with the disability community and said, hey, could we, let's start talking about this, because it is very important for us to provide this option of communication, especially in our community where we have high numbers of folks who use ASL. And that was a learning experience for us, but it's a way where we saw policy not catching up. And although we would probably have done it, even if policy didn't say we had to do this, and it is also the right thing to do, sometimes there will be blind spots. So as you look at your in-house process, as you look at the information that the healthcare informatics teams, for example, providing us reports on what is happening in terms of where we can improve, we start using that information to build upon our services and ensure that people have the best access. The other piece, a huge piece, is if you're providing a significant amount of communication to folks in written formats, do you have a standardized process for everything that you produce to go through one point of review or check or a repository? And that could seem like a big bottleneck for some folks, which it can be. I'm being very, very truthful here. However, without that repository or bottleneck, you may not be able to capture 100% of the communication that is going to your population. And if a person asks for a standing request for alternate formats, you want to be able to honor that. So building a culture of standardization or standard communication within the company is incredibly important in order to capture all that information and be able to transcribe it. Because I have a team of transcribers or folks that send the transcription over to a transcription agency. If they can't pull the information from a repository, in our eyes, that from that technician's perspective, that information doesn't exist. Therefore, it doesn't get pulled, and therefore it doesn't get transcribed. Therefore, the member does not get the information. So it's important for understanding too, how do you ensure that your team has a place where they put every single communication in that can be pulled, and also that can be pulled at the individual level if you do have individual communication that is being sent out to individuals. And then also, I talked a little bit about the standing request. So standing request is when a member says, um, uh, Carla, from this point on, I'd like all my communication to be in Braille because I do require it due to a disability. So, why is that important? Why is it important to have the option for a standing request? Think about the amount of time that it would take and the disruption in service that it would cause for an individual to have to call every single time for letters. And then members don't sometimes know what letter we're going to send them. So from a civil rights perspective, from an ADA perspective, having a standing request is really a way for us to streamline that equity across the board for individuals with access and functional needs that require alternate formats. You can also say, well, you know what? I don't need to get everything in an alternate format, but I do want this letter to be in alternate format this time because I want to keep that for posterity. I want to have that readily available for me, and if I want it in Braille so I can quickly read it. Perhaps I want my ID card in Braille because Braille will give me the opportunity to read it on my own or in audio, and I can read it on my own. And Carla will give some examples of that next. So we'll go to the next slide.
And so here at IHP, we actually did run a report to see which one of our members currently have a standing request. So just to give you a little bit of insight of what that process looks like for our team is that every morning we receive an actual report from Healthcare Informatics letting us know which member has a standing alternative format request, and if that member currently has a letter that has been sent out to them. And so that's kind of what our process looks like for standing request. So if you see here on the screen for large print, 89% of our members that have a standing request have requested large print. 7% is audio, 3% is electronic, and 1.6% is Braille, and 0.2% is text to ASL. And with DHCS recently sending all health plans a report informing them of members who they've identified who have requested an alternative format, once we received that information, we noticed that our standing request is actually going to increase by 1,500%. So our team does have a lot of work ahead for them, but we are ready to, provide the alternative formats for our members. If we can go to the next slide. So with this next slide, I actually wanted to, and you guys can use the chat feature, but as a health plan, we do come up with different scenarios that always occur, especially when we're talking with our members and knowing that they have alternative formats. And so when a member contacts member services, sometimes they do request for them to receive a standing request, or sometimes they receive for just a single document request. So with these scenarios, I just want to give you guys a little bit of stuff that we here at IHP have kind of come across. So a member who is blind calls the health plan and asks for a provider directory in Braille. And so as a health plan, what do you do in this case? So just to give you an example, here at IHP, our provider directory is about 400 pages or so. Every year I know that it changes, but it's about 400 pages. And so it wouldn't be so much reasonable for the member to receive 10 boxes of just Braille documentation, and it's time consuming for the member to actually go through the whole documentation that we've sent them. And so when we do in cases like this is we actually contact the member. We do inform them that we received a request for a provider directory in Braille. We explain this, that the actual documentation itself is about 400 pages, but we actually ask them, is what information is it that the member might need, or if there's a different format they might want to receive this specific documentation. Now, with a single document request, it's not going to affect our standing request because that's a different ask. And so in this in this case, we were actually able to provide the member with an electronic format of the section that the member was actually requesting. And so the second scenario is a member with low vision is unable to memorize their member ID number. And here at IHP, one of our benefits that we assist our members is with transportation. And with the current process to verify transportation services, when the transportation company would go to pick up the member for their appointment, they would place a call to the member, and member actually had to verify either the last four of their social or their member ID number. But when we switched the logistics company over, unfortunately, due to personal health information, members had to verify that they are the person being picked up by providing them their member ID number. Now, here at IHP, our member ID numbers are about 14 digits long, and I wouldn't personally be able to remember a 14-digit number. So, member was upset because they kept having issues with their transportation, either not picking up on time or not picking them up because they were unable to verify. And the IHP ID card is so little that even the numbers on there would be too small. And so what we actually did was just thinking outside the box. We said, well, how can we provide something that, a recorder that's going to, where the member can carry it with them, because if they're at an appointment, they're not going to carry around a CD player with them to read out the member ID number out loud. So we actually came together as, just quickly thinking outside the box, and we ended up recording the ID number on a Telrex little device the member can be able to carry around with them. And it's only about a 10-second recording. We were able to record the member's ID number on there, and we mailed that information out to the member. A member has been utilizing the Telrex to be able to read the number back to the logistics company to verify that is themselves, to be able to utilize the transportation services. So just little workarounds that we've been able to assist our members. And so another scenario is a member with low vision stated he can no longer receive his materials in audio CD due to him not having a device to hear the audio. And so with this particular case, member lived at home with his son, but his son actually worked out of the area every so often. So he was most of the time only there with his IHSS caregiver, and he didn't feel comfortable having his IHSS caregiver read the documentations or the letters he would receive to him. And so when he called us to inform us that, he no longer wanted to receive his material in audio CD, and he just wanted us to completely stop, we asked the questions because we know how important it is for members to always be informed as to what is going on either with our authorizations or with members' care. So one of our team members placed the call. We asked, what was the reason behind it, and, see if maybe we can assist with sending it electronically. One member informed us that the reason why they wanted to stop receiving alternate format was because the CD player broke and he didn't have enough money to pay for a new CD player. And so looking at, what the cost would be to sending him a CD player to be able to still receive that information for him is very valuable to the member. So we ended up, the health plan ended up purchasing a CD player for him to be able to listen to his audio CDs when he received that alternative format by mail. And so the other case scenario is that we had a member with low vision who was requesting to receive his material in Braille, but he did notify us that he did not read Braille. So when it comes to alternative format, we want to ensure that members who are receiving the information are able to understand the information that is being sent to them in the format that is being sent to them. So in speaking with the member, he did inform us that his provider informed him that he was slowly losing his vision and would be completely blind. And so he wanted to learn Braille. So member was not informed of other resources that were out there to him. So we ensured to connect him with the Braille Institute. And in the meantime, we informed him that instead of receiving his information in Braille, because he's going to receive the information and not be able to read it yet, is, what about if we send it to you in either large print or an audio CD? So we're able to not only, assist the member with resources, but also providing the correct format for the member's need. And so as a health plan, and there's a lot more scenarios that we can go over, but as a health plan, we've noticed that, it's not just, when a member calls in to receive an alternative format, sometimes we have to still do that connection. So part of our process is that, even though we might receive 10 requests for alternative format that day, which hasn't happened yet, it's still a little low, but anytime we do receive that request for alternative format, we want to make sure that we're making that connection to the member to inform them that they're still going to receive their standard letter in normal format, but then within a few days, they're going to be receiving that information in their preferred format, just to be informed. And a lot of the times, the members aren't sure that there's other formats that they can receive. So it's always great to have that communication with the member. And so if we can go to the next slide, please. And so once again, I know myself and Gabriel's information is here on screen. So we do want to thank you for attending the webinar. And I believe next would be any questions. Is that correct, Louis? I know that we have a few questions here
That's
on our
right.
chat.
That's right. Thank you. Thank you, Carla and Gabriel. You guys did a great job. Very informative. All right, everyone. This is the time if you have questions to submit those in the chat, and we're going to start with them right now. So, oh yeah, let me turn on my video. Okay, so the first question that I see here was one which asked when you were talking, Gabriel, about would you use a similar approach for limited English proficiency with folks with literacy issues such as reading or comprehension?
Yeah, no, absolutely. So, in terms of what policy governs the access to this, there might be some questions, especially in the size of your organization, whether you're required to provide this or not. At IEHP, because we do have a system in place to do this, it's not a heavy lift. So we have had folks that qualify under the literacy component where they could use audio. So maybe not folks that have a communication disability, but may have literacy limitations. We can apply the same process that we use for folks with disabilities to remediate that as well. So, again, the ACA does, the American, the Affordable Care Act does address the importance of communication and ways for us to be able to provide that to individuals with limited English proficiency as well. Instead of getting too caught up in the policy, I think for us as an organization, doing the right thing, if we have the resources to do it, let's just do it and build it in. So we have had instances where that has a person who has limited English proficiency or because of literacy would receive an audio, and especially around our team that provides health education courses. For example, they come across a lot of health literacy limitations, and we do work with them to provide the materials to individuals in audio format when needed.
Okay. The next question is real-time captioning during in-person communication is important for some of the consumers I work with, particularly those with auditory processing challenges who need to be able to read what folks are saying in order to understand their words. It seems this kind of format is not readily accommodated in most clinics. Do you have best practices for this? Unfortunately, clinics often are cell-signal dead zones without Wi-Fi for patients, so smartphones cannot fill the gap like Google Live Translate since they need internet access for accurate descriptions. So do you have any suggestions for the best practice for these circumstances as well?
Absolutely. So if you're the consumer, I'd say reach out to the payer. So whoever pays for the service has a responsibility to address access issues. Whether the responsibility is delegated or not, whether the authority is delegated or not, the responsibility still sits with the payer according to the ACA. So if you're talking about a healthcare space, or if you're talking about a government provided service, my suggestion is connect with the organization that is providing that service, or sorry, that is funding that service. Because often what happens is that these smaller clinics, again, may not have capacity to provide a reasonable accommodation because of the cost, that may be implied. Now, one of the things that we've done at IEHP, we have assumed responsibility for all communication pieces because we know it's at the core of providing quality healthcare. And we retain that and do not delegate that and blend it into the rates that we pay the provider because we understand just how important that is. However, in hospital spaces, things might be a little bit different and depending on the state you live in. In California, actually, the legislature decided to build or to put a law on the books, specifically saying, though, that even hospitals in California can bill the payer for these services. However, they are responsible still for providing the infrastructure needed to do this work. So my recommendation to keep it simple for the consumer is call the payer, the insurance company, and let them know their limitation and ask for an accommodation formally. Because many times the requests might come in as like, hey, do you think you could do this? And then the person on the phone may not understand what you're asking. But empowering consumers to say, I'd like to request a formal ADA accommodation for the X, Y, and Z. Now the organization has a responsibility to provide a response, either approving or denying your accommodation request, or negotiating with you to figure out what the most reasonable option may be based on the ability for the organization to provide that. With that said, too, that also facilitates the process for any DOJ inquiry that you may have if you do choose to take that a step further and raise that up either to the Office of Civil Rights with Health and Human Services or go directly to the Department of Justice for an inquiry.
All right, next question. Does Inland Empire Health Plan have experience developing clear, plain, or easy read language materials? Our team is finding gaps, improving providing support to patients with traumatic brain injuries, intellectual and cognitive disabilities, acknowledging that there's overlap in the need of alternate technology also.
Great question. So one of the things that is standardized for Medi-Cal Health Plans is that we cannot use language that is above the 5th grade level. Carla, is that the grade? Yeah. So we
6th grade. Sorry,
6th grade level. Now, with that said, there's individuals who may still struggle with that level of communication. Again, I think that the important piece would be to let the provider know, or let the payer and the provider know that you have this limitation. And we will start exploring perhaps what are some ways to do that, because we may not be able to do it as a standard practice for our entire enterprise, but can we start tailoring a specific individualized plan for this individual who requires it? I will also say there is this other benefit that's available for folks called habilitation. Habilitation services often cover some of these aspects that you just mentioned, and certain folks with TBI may qualify, or individuals with developmental disabilities may qualify for habilitation services that could facilitate in this space, perhaps not address it all, but facilitate in this space as well.
Thanks. And Carla, I think somebody was asking when you were going over APL, the abbreviation for what APL means. They wanted a reminder of what that was.
APL is all plan letters, and these are letters that DHCS typically releases. Anytime there's a policy that needs to be implemented within the health plan, they will release these all plan letters to the healthcare.
And DHCS stands for Department of Health and Services in California. And they are the regulator of Medi-Cal Health Plans.
Right, thank you. Any recommendation for clients that are hearing impaired that don't know ASL?
Carla, do you want to? I know you're pretty familiar. I have some recommendations, but I think you might have a few as a ASL interpreter.
So I do have family members who are, and this is just personally, who have profound hearing loss who do not know ASL. And a lot of the times the recommendations is writing things down. We go back to writing things down because even for them to read your lips, a lot of things can be lost when reading lips. And so writing things down. And I know that sometimes it can be a little bit of time consuming, but if the client is not fluent in ASL and we want to ensure that we're not losing any nothing is being missed within that communication, the time we're communicating with the member, is we do have to write information down. The other thing would be to provide anything in writing ahead of time. So if there's any materials that are going to be shared, either if it's a classroom setting or a setting where they're meeting with somebody else, is providing those materials ahead of time.
And I think one of the things that we train our provider network and in some of our trainings is our interpreters utilize this as well. They either have electronic whiteboards or you can have a notepad where the key pieces. So if you're talking about, for example, a provider prescribing a medication, you write down the frequency or in the name of the medication, the frequency of the medication, in a very clear way so the person can visually see that. And if there are any questions, those can be addressed. So, when taking the history, when prescribing, some of those pieces can be crucial to the plan of care.
Great, thank you. Next question here, I believe you answered, but let's see. We are working on providing alternative formats for our members. Could one of the panelists give us an idea of what percentage of members, all of them being either Medicare or Medi-Cal?
Yes, so we actually do have a percentage of both. I don't have the actual percentage, but I can tell you that our requests are more Medicare than Medi-Cal. But currently right now we do have both members who are either have Medi-Cal or Medicare who have requested alternative formats.
Great, thanks. Hearing loop technology. Is your organization utilizing portable loop technology at the points of contact to assist clients with hearing impairment who have hearing aids with T-coil installed?
Yes, we are. So at our administrative facilities and our community resource centers, IEHP does provide that access. There are some rules and regulations around code, depending on the capacity of a building or a business in order to provide these assistive devices. In terms of, again, if a member, because we don't delegate communication responsibilities out, but unless it's prescribed by local code, in these instances, again, the recommendation is contact the payer, contact the insurance company, and if we need to deploy, if that's all we need to do in order to ensure that somebody has amplification during their visits to a provider, then we could do that. I will say, you might say, well, why don't you do this for everybody? It's a cost thing too. So I know that our amplification devices here, for example, they're not used robustly, but we have them here because we meet the criteria for the size of the facility and so on. We also know it's the right thing to do and we have the resources to do it. Could we do that for every single facility around the Inland Empire? And would that be the best use of resources for that? And have to, cut into, perhaps real-time captioning if that's something that is needed for specific care? I will answer this with that's a question mark, and you have to evaluate that depending on your budget, depending on your capacity, and so on. But my recommendation is let the payer know that you need this, and perhaps this is something that we also look from a cost-benefit analysis. Perhaps it's cheaper to give the device to the member and provide them a kit than expect each provider to have one. So perhaps paying for that kit for the member to have could be a better solution than expecting every single point of care and put the burden on the member to kind of request it for every single point of care. So a lot of these things are always a negotiation, and not a negotiation because am I getting my rights or not? I don't mean it in that context, but a negotiation of like what actually works better for you and is going to kind of be the most effective and most impacting. And believe it or not, often the most impacting and most effective solution often is also the cheapest. That's something that we see time and time again. So for example, like with a Braille, for example, if I give you 15 banker boxes for a provider manual, that can cost $25,000. But you might just want to find a provider that's in your 5-mile radius. Perhaps an electronic version of that is more appropriate. And if I give you a Google Chromebook that costs $250 and it's going to allow you to read other things in e-text, that is cheaper than providing you the actual material, the actual physical material, if you're able and have the ability to use a Chromebook and the technology there to do that. So it's always a let's find out what be the less cumbersome thing, the most effective thing for you, and the ADA coordination team in the organization needs to be able to kind of work with the client. And here at IHP, we're very flexible. Other organizations might be a little bit more rigid. So it's building a culture of flexibility that honors the individual's disability. And I think that's at the core of the ADA, honoring individual needs as best as we can in the most cost-effective way.
Great, thank you. The next question is, do you offer speech to text?
So I'll answer this question in a couple of ways. So if a member says I need captioning services at point of care or that, so yes, speech to text would be provided if that's the most indicated and that's what the request is, and that seems to meet all the criteria. Yes, and part of a standarding request, what we could do, for example, if a person would like audio and then have audio to text enhancement, in that the transcription company has the ability to do that. So it's just a matter of, if it's learning disability that the reason why this individual is requesting it, or a disability that requires the audio and the text at the same time, we could look at that. So the capability is there. I don't think we've come across that category yet, Carla, right? In terms of the audio and the text, the speech to text.
Yeah,
Just
I know
caption.
that. Yeah, correct. And I know that currently right now, since a lot of the meetings that we've had here at IHP, where we invite the community or they're part of webinars, captioning, we ensure that captioning is always provided to our audience.
Great. Next question, and I'm going to sort of shorten it because we're running short on time. Do you have any opinion here about why clear masks haven't been adopted by the medical profession? Some people who are writing a few things in the chat had raised the question of why that would be, and that there's face masks are very difficult for people hard of hearing, but not the deaf community, of course. But any idea about what that would be, or what would it take to get that to be adopted more?
Well, I'll start off with an elephant in the room, and masks have become a political thing in the United States, number one, right? That's just to start off in that context. Number two, although we do know that in the medical environment that there is more of an understanding of the protection and what happens with masks, the individuals, the human beings doing the work, although they might be scientists themselves, probably still have a political opinion about things. So that's number one. Number two is the availability and the prescription of this. I don't believe the CDC has promoted this type of mask the same way that they promoted other types of masks, and with the same kind of visibility, the same type of, even in the drawings and the communications that are sent out. So I do think that to a certain extent there is lack of understanding of the effectiveness of these masks, lack of understanding of whether these are compliant, and so on and so forth. However, that doesn't make folks off the hook in terms of ignoring the responsibility for communication access. So again, if this is something that is a concern, the best thing to do is to communicate it to the payer in a healthcare setting. Now, again, this is going to be complicated because now if you have different points of care, every single point of care will need to be addressed in this space. So unless there's an overarching policy that governs across the board, which again, remember we said this was political, you're going to have some issues in terms of implementing something like that. So what are you left to do in that situation? put the burden back on the provider and say, okay, you're not willing to wear masks, the ones I'm offering you an example, but what can you do to ensure effective communication in our interactions? I'm formally requesting effective communication as an ADA accommodation. What can you do? Put it back on them and let them together with you come up with a solution and see what that ends up being. And perhaps it might be the mask, because that, again, remember what we said, sometimes the most effective is the cheapest option. And time again, I've seen that happen over and over again. The most effective option is a cheap option. Even if it's not cheap in the actual service itself, it might prevent disease later on. It might prevent miscommunication later on. It might prevent other issues that could have been avoided had clear communication happened.
Okay, great, thank you. Just a few comments here. We'll run through some comments and resources. One person said, just like you can have VRI, you can have remote cart. So I don't know if you wanted to respond to that, but that was one thing. Another thing there, somebody put hospital kits to facilitate communication with deaf and hard of hearing. People are available, and they gave an example. I'm going to copy that and put that into everybody into the main room so you can see that. Okay. Are those, somebody followed up, I think this is about the APL conversation, and are those available to the general public?
Yes, they are. And actually I can, what I can do real quick here is I can give you the link, Louis, and then maybe you can push it out to the rest of the session.
Yeah, or you can choose everyone and that'll be fine. That'll work.
I think for some reason I didn't have the everyone option.
Okay. All right. Well, then send it to me and I'll send it.
Okay.
While you're doing that.
Oh, I do now. Okay, there it is. I see it. There it is.
Okay. If a request is placed by a member who has Medicare or Medi-Cal, does that request automatically fall under Title II because government programs pay for the services?
Great question. It depends. So it depends. It depends on, so I want to say yes, Title II because of it. There are some nuances in ways that some designees of services, because you also have PACE programs, you have other types of service deliveries that may meet the burden to go over to Title III of the ADA. But with that said, the ACA is very clear that if you do receive federal funding, you still have to honor the Americans with Disabilities Act. So perhaps, and this is why I hesitate to say yes, is for us, we're a public entity, right? So if you want to come to our governing board meetings, you are covered under the Title II of the ADA for that service. If you want to do that for Humana or for some other type of organization, they may be covered under Title III for that component, but Title II for some of the service delivery pieces. So that's why I hesitate to give you an overall answer. Perhaps the Pacific ADA has a better one. That would be my my thought process on that one.
Yeah, I think that, you know, sometimes these questions are very technical, and that kind of a question, if it's really important to you, I would recommend that you call us at 1-800-949-4232, because as Gabriel was indicating, there's some nuances there that are worth going over, and probably doesn't need to happen with everyone here on this call right now. The next question that I see here was the person said they felt like they weren't clear about what their question before. What percentage of your plan members have requested alternate formats? That was their question. Do you know that?
So I don't know if you can see that right now, Gabriel, but it's a very that have come directly to the health plan. You know, it's a very low number compared to the actual members we have enrolled here at IHP. But that will be changing due to the list that DHCS provided to us. And the list basically is just informing us that members who they contacted actually requested alternative format through their platform. And to ensure that we're both working together and we're being in compliance is now we will now actually implement these requests in our systems. And so that's where the increase of percentage that you saw all the way at the bottom, which was 1,500. We did the calculation, so we would be seeing a very high number of new increase for our health plan for alternative formats coming very soon.
And I went ahead and did a quick rough and dirty calculation. And again, because we're in that state of flux, roughly between 0.5% to 0.8%.
All right, good. And let's take one more here. Is there information to teach hard of hearing members about requesting CART or captions to obtain equal access and effective communication for their medical appointments?
Is there a process? So the process would be with IHPs, you can let your provider know that you require an ADA accommodation, and they are trained to do that. However, this is the one where the caveat is you might be the first person to ask them in this person's 25-year career, 10-year career, whatever it might be. So they might not know what to do with that. And if they don't know what to do with that, then you go one tier up, and that's the health plan. My hope is that our team is more trained on this, because we do refreshers quite consistently. There is standard operating procedures that we have in our call center, where they will then task what is known as an ADA accommodation request to a specialized team of ADA professionals within our independent living and diversity services team. They will then process that request in partnership with our provider services and make sure that we have that available for the member. Now, again, this is IEHP, that might work differently. So in other health plans, but my recommendation is if the provider gives you kind of a blank stare and you don't have confidence that they're going to be able to resolve it, go ahead and put it one level up and see what happens. And if that fails, then you have your options with Office of Civil Rights with Health and Human Services, Department of Healthcare Services in California, DMHC in California, or DOJ if you just want to go nuclear. So, but I say always start, at the next available tiers, and most of the time those things get resolved pretty quickly if you go that up that chain. Now, with that said, I don't expect everybody to know what the chain of command is, and that's not a reasonable request from the public. So pick whichever one is the most readily available to you, and invoke that ADA accommodation request, and try to get relief that way.
Great, thank you so much for that anscer. All right, we realize.
Call Lewis. Can I say that too? Call Lewis. Call his team, because I think Pacific ADA can also help with finding, right, Lewis? I mean, you guys
Correct.
are also a resource. Or you're
Always call
the Living Center. Yes.
Yes, can always call the Pacific ADA Center for any questions around that. In fact, that's what I was just about to say. We realize that many of you may still have questions for our speakers, and apologize if you didn't get a chance to ask them your question. But if it does revolve around the ADA, you can contact us at the Pacific ADA Center at 1-800-949-4232. If it's something much more specific, you have Gabriel and Carla's information there on the screen that you can contact them. You will all receive an email with a link to an online session evaluation. Please complete the evaluation for today's program, as we value your input and want to demonstrate the importance of the program to our funder. We want to thank Gabriel and Carla today for sharing their time and knowledge with us. It was a great presentation, really helpful and informative. And a reminder to all of you that the session was recorded, or is being recorded, and it will be available for viewing next week at adapresentations.org in the archive section in healthcare. And our next presentation, our next webinar is planned for August 25th, but do watch your emails for the announcement of opening of registration for the next webinar, whenever it is. And with that, again, thank you very much to Gabriel and Carla, really appreciate it. And that's gonna do it for today. Have a good rest of your day, everybody. Bye-bye.
Thanks again. Take care.
Bye. Thank you.
Bye-bye.